I'd like to introduce our next speaker, which is Dr. Rosa Gonzalez-Guarda. Rosa is an associate professor in the School of Nursing at Duke and an assistant dean of the PhD program. Her research describes the intersection of intimate partner violence, substance abuse, HIV, and mental health among Latinos in the US, and the development of multi-level interventions to address these. She uses a syndemic orientation, mixed methods, and community-engaged strategies to influence practice and policy changes to promote health equity for Latinos, survivors of intimate partner violence, and other historically marginalized population. Today, Rosa will speak on the syndemics of HIV, substance use, interpersonal violence, and mental health.
Thank you. Thank you so much. I am so excited to be here with you all. It's been wonderful to learn more about CFAR, and I think we've had such great conversations so far. I'm looking forward to continuing that. As was mentioned, I'm going to be focusing on the syndemics of HIV, substance use, interpersonal violence, and mental health. And what I hope to do today is really walk you through my journey in terms of arriving to syndemics and demonstrating how we can use this approach in our own work as we think particularly around the prevention of HIV and the syndemic conditions. And I'm going to be using my work in the Latino community and more recently in the immigrant community, specifically here in North Carolina, to demonstrate the utility of the syndemic framework in not only understanding sort of the risk and the context of HIV, but also in the intervention strategies that we can design together in collaboration with our communities. I like to start in terms of my own origins of my perspective. I was born and raised in Miami. I'm not so sure Miami's the South. Very unique context. And actually, I will be sharing some of the unique findings that I've found in my work in Miami versus here in North Carolina that has had implications in terms of thinking about HIV risk. But I come from an immigrant family. My parents came from Cuba, and I grew up in an enclave in Miami where I was part of a majority group and experienced a lot of protection from that enclave, growing up with ethnic pride and being able to exercise my culture. And so I come from an upbringing that brings a lot of strengths, and I approach my work with a lot of gratitude and trying to make sure that all populations have those same kinds of experiences I do. I also wanted to show you this picture because that's me in the middle, and I've grown quite a bit. I'm still working on that chub back there, but that's a conversation for another day. So when I first started doing research and actually working as a nurse and a public health nurse in particular with the Latino community outside of Miami, I started recognizing that there was some unique risk that existed outside of my enclave. And in my experiences doing research, I kept on coming up with some common themes of inequities in the Latino community. More recently, or further along the road, I started to really be interested in HIV and sexually transmitted infections in particular, and then had opportunities to do work with dating violence in Baltimore, and I kept on seeing some commonalities between the experiences and the risk around what makes Latino women at risk for HIV, and also what makes Latino women at risk for intimate partner violence. So in my mind, I started to make these links together. I also came across just like an overwhelming underrepresentation of Latinos in research in general, and particularly in the design of interventions that are designed for that population. So that has been the foundation of some of my interests. Also, on top of my own observations working with the Latino community around HIV and intimate partner violence, I came to learn around this phenomenon that we see with immigrant populations, which is called the immigrant paradox. And you see an example here of the immigrant paradox as it relates to lifetime prevalence of psychiatric disorders. The line that you see in blue are non-Latino white populations. And you can see that in the US-born population versus the immigrant populations, that there's much more a higher rate of any psychiatric disorder than in the US-born population than those that are immigrants. And this is called a paradox because today we're focusing on social determinants of health and health equity. And it's a paradox because despite some serious disadvantage related to resources, education, opportunities for jobs, immigrant populations tend to have a more favorable outcome than US-born populations. And through time and across generations, you see a decay of this protective factor that immigrants come in. And so we became very interested in trying to understand what that means in terms of HIV risk, intimate partner violence, and the other syndemic conditions, and trying to understand really what's in the context here in the United States that's really making immigrant populations sick in terms of these outcomes. So the behavioral and mental health conditions that I've been focused on are substance abuse, HIV, IPV, and mental health conditions, specifically depression and anxiety. And these conditions follow this immigrant paradox where you see much lower rates across all of these conditions among immigrant populations. And the longer they're here in the United States and across generations, you see a decay and an emergence of disparities and inequities in these conditions. So I'm particularly highlighting intimate partner violence because although I have studied these conditions as a unit, and I'll describe the perspective there, intimate partner violence has always emerged as the most prevalent of the conditions that we study. And drawing from doing a lot of community engaged work, it's often been a priority of the communities that I've worked with. So I've also done a lot of work in the area of violence prevention, intimate partner violence prevention. So now moving on to this concept of syndemic and how I got here. When I first started doing work with Latino women and Latino men, both heterosexual men and men who have sex with men, we did a lot of qualitative research. And we were trying to understand the relationships among these conditions. Is substance abuse a risk factor for HIV, or is HIV a risk factor for substance abuse? What are the mechanisms linking them? And we would ask our participants, and they would use this metaphor of a tree. They would talk about, these are all branches of one same tree. They're all intertwined branches. And we would, ask them about, what is connecting these branches. And they would talk about these conditions as a result of social problems. Of the social problems of being here in the United States and working multiple jobs and not being able to spend time with family, feeling discriminated against, feeling oppressed. And they talked about the social problems as being really like the breeding ground for all of these conditions to emerge. And so when I was trying to make sense of this is when I came across Meryl Singer's work on syndemic. Meryl Singer's a medical anthropologist who first coined the term syndemic, and the first syndemic that was coined was the SAVA syndemic, the substance abuse, violence, AIDS syndemic. And ironically, he coined this term working with Latino, Puerto Rican women in particular in Hartford, Connecticut. And he was interested in understanding the risk and the link between HIV and substance abuse, but also realized that that was impossible to look at without considering intimate partner violence and other forms of violence and oppression that this population experienced. So I think one of the key concepts to understand around syndemics is that we often talk about co-occurring conditions or comorbid conditions. And in our conceptualization of comorbidities, we think about two distinct conditions that have a distinct etiology, right? From a syndemic perspective, the idea is that these are conditions that cluster in historically marginalized populations, and rather than having a distinct etiology, they actually have a common etiology. And in terms of thinking about how this guides our work, the perspective is to understand what links these conditions together so that we can focus on those links and develop interventions for those links, and then ultimately have an impact on multiple health outcomes at once. So it's very exciting from a public health perspective because the idea here is to design interventions focused on links that could have a bigger bang for your buck in terms of the investment. So after coming across this syndemic orientation, I started to try to develop a theoretical basis for this as it applies to the population that I worked with. And so we developed a framework to try to understand the connection between the syndemic conditions and trying to look at it from an ecological perspective. What are the most important links that we can learn about in our work so that we can develop interventions for this? And in doing that research, we found a number of things just to highlight. First is that when we tested this idea that syndemics occur using a measurement model, that we found that there was a measurement model for syndemics. And so we've been using the syndemic factor to really measure syndemics in the populations that we worked on. And then more importantly, which what you see on the slide, is trying to find out what are the predictors. And we have found very much like I shared with you in terms of the immigrant paradox as it relates to the syndemic. So higher levels of American acculturation, higher levels or a higher time of living in the US, we find that these syndemic conditions occur more frequently. The interesting thing too around this work that on syndemic measurement is that we also found that when we looked at syndemics in Latino men and Latino women, there were some slight differences around how those conditions configured. So with women, substance abuse was an important part of that syndemic. And you can see that is represented here in this model. But when we look at men, substance abuse falls off in terms of being part of that syndemic. And I think part of that is because substance use is it's so culturally acceptable. Binge drinking is a common practice for men that is not as much of an indication of risk as what we see with immigrant women, where substance use is not as much of an accepted behavior, and so it's more indicative of risk. But the other important thing here is that we found that out of all the things that we've studied around potential links, this acculturative stress box that you see right there in the middle with a 0.70, that was the factor that had the biggest influence on the syndemic. And what acculturative stress is the stress that's experienced by Latino immigrants related to the acculturation process. So I think it's a really good measure of really quantifying what is the internal lived experience of being a Latino living in this US society that really represents that sort of like toxicity that might be explaining decays in health over time. I'm so glad, Michael, that you're taking time because I can get too excited here, so please let me know. So given that acculturative stress was such an important predictor of the syndemic outcomes, we also started to try to understand, trying to understand this syndemic is what are the biological processes here as well that are intertwined and potentially contributing to risk in syndemic outcomes. And so we started to try to understand, there's been so much work on the weathering hypothesis in Black Americans and a lot less done with Latino immigrants in the US. And so we started to get really interested in trying to understand how those exposures to US society is really getting under the skin and contributing to the emergency of health inequities and also clustering along with the syndemic outcomes. And so that brings me to a study that we just recently completed that was funded through the National Institute of Minority Health and Health Disparities that's really focused on trying to understand over time how acculturative stress and then more importantly, resilience factors interact to influence syndemic outcomes and biological stress. So just to give a little shout out to our team of investigators that included people from the community. We had community co-investigators that are very much involved in the leadership of community organizations. We also had bench scientists that were helping us with understanding the biomarker component of this research, which was a bit newer to me, and then some early career investigators. Many of these faces may be familiar to you. And one of the important things of our project as well is that we had a lot of representation from the local community on our team. So we had community health workers that actually were part of the research team, and a lot of sort of cultural, racial, and ethnic diversity in the team as well. So our aims were really to look at over time, what the influence of acculturative stress and resilience factor had on syndemic conditions and also biological stress. And so to bring us back to our conceptualization of syndemics, these conditions of intertwined branches of a tree, we added in our trying to understand this, the role that biological stress was playing on that. And then, fortunately, during the life course of this study, we also had COVID happen. And so we saw that, unfortunately, our Latino community was disproportionately affected by COVID, especially in the very beginning of the pandemic. And so that, that was integrated into our approach. And I think as we've evolved our understanding of our syndemic is really thinking about, very much like a tree that's exposed to a harsh environment. There's opportunities when a tree is hit by harsh winds for those roots to be solidified. And those roots are really those resilience factors. And so a very important part of our study was really understanding what are those roots that are protective, that could buffer against the harsh environments in which Latino immigrants live. So this is a longitudinal study of 391 Latino immigrants in the Research Triangle area, and they were between 19 and 44 years of age, and they had to have lived in the United States for a year to participate. We did all our activities really using principles of community engaged research. I would love to talk more about that, one of my favorite topics to be able to talk about. And these are the measures that we can refer to if we have questions about those. Just to point out some of the characteristics of our sample, we had the majority of our sample were Spanish speakers, so there were a relatively low acculturated group. A lot of these participants weren't racialized yet, so I always say we ask very harsh questions around sex, trauma, drugs, violence, and our participants know the answers to all those questions. But when we ask them about race, they don't know what their race is. Actually, about 54% of our participants said that they don't know what their race is. Now, the participants that did know what their race is, those were also more likely to experience discrimination or report experiences of discrimination. And then another important thing I wanted to highlight about our sample is that about a third of them were undocumented, and the vast majority of them did not have health insurance. So 70% did not have health insurance. And so this is the results of that same measurement model and the way it looked here in North Carolina. You'll see that on the right, those are the syndemic conditions. And when we measured this here, HIV risk it didn't fall within the syndemic conditions. And I think part of it is because the nature of our sample were Latino immigrants, and as I mentioned, there's lower risk among immigrants, that we didn't have enough risk indicators to really represent risk and include in the outcome. But we did see again that the most influential factor for this endemic was this acculturative stress, and you see that there. I'm going to skip over this a little bit. So what we have done is also demonstrated the impact that acculturative stress has on a myriad of physical health consequences. So our team has done a systematic review and really highlighted a lot of physical outcomes, even at the cellular level. And we've also reported, observed consequences related to self-reported physical health and sleep disturbance and fatigue. So just to go back also and talk a little bit about the different acculturative stressors. Within the measure that we use, we look at different domains of acculturative stress, and they range from things that are very much in the family level, such as cultural conflict or marital conflict and the stress that has when one partner is more acculturated than the other person. But there's other things that are related to stress, related to the occupational stress. So the idea that potentially that because you're a Latino immigrant, you're working harder and you're getting paid less. is one of those questions. And we've seen some correlations between these subscales and some of the inflammatory cytokines that we're measuring as part of our biological stress outcome. So based on the findings of this, and I skipped over a little bit some of the resilience interactions, during the COVID pandemic, we were able to work with 10 community health workers that were already doing COVID-related work and very much embedded in the Latino community. We worked with them to design an intervention that was focused on addressing oculturative stress and building those resilience factors as a way to address and prevent syndemic conditions during the COVID pandemic. And we found, in a pilot that we were able to reduce oculturative stress, reduce COVID-related risk behaviors, and reduce depressive symptoms. And our team right now has a application that we're trying to get funded. In second revision, we'll see how many times we have to go in to try to test this strategy more rigorously in a randomized control trial in the community. So just to summarize some of the findings that I shared with you. HIV, of course, occurs within a syndemic of other conditions. Intimate partner violence, substance use, and mental health are really key conditions to consider within that syndemic perspective. But the syndemic looks differently depending on what community we're working with. I shared with you that we found differences in looking at this between men and women, especially as it related to substance use. When we did this work in Miami, where there was higher levels of HIV risk behaviors, versus here in North Carolina, the emergence of HIV as part of that syndemic was very different. So as we think about our syndemic work, I think it's important to think about the nuances of how these conditions configure according to the specific populations. It's also really important as we look at the clustering of these conditions to try to understand what the underlying links are. And those underlying links are really critical for us in terms of trying to advance the field of prevention in addressing the clustering of these conditions. In the work that I've done in this population, in the Latino immigrant population, oculturative stress is really a key link that needs to be addressed. It may be something differently depending on what group you're working with, but I bet you it's related to the social and structural powers that exist in U.S. society or whatever that that structure, social structure is, if you're working in a global context. So being aligned and understanding what that environmental structure is really key to the effectiveness of our interventions. And just to thank our collaborators, especially the promotoras, community health workers from El Centro Hispano, who really helped us in developing this intervention. Thank you.
Thank you, Rosa. What questions would you like to ask Rosa?
Okay, thank you very much. I'm one of the Spanish-speaking HIV providers in clinic, so I see the weight of the stigma among the women that we see in our clinic. And in our PrEP clinic, unfortunately, we have very few Latina women as of yet. But my question for you is about how you didn't see HIV kind of come up in that syndemic model. And was it because they're not feeling comfortable answering those questions that you alluded to initially, and they're more comfortable answering those questions in Miami? Because I do worry we're underestimating the HIV risk as a result.
Yeah, I do think that there was definitely some measurement issues. One of them was that in the work in Miami, we screened for sexually transmitted infections using biological screening. So we tested for sexually transmitted infections beyond just having self-report. Here we didn't. We just did self-reported. So I think that there was some different ways that we were measuring that as a consequence didn't fit. But I also think on top of it there was just less risk behaviors. We know in Latino women the primary reason for getting HIV is not the woman's behaviors, but their partners. These are mostly heterosexual women. And so we also saw like lower risk in the partners when we asked them about partner risk behaviors as well.
Okay, it's me again. One of the questions or statements that I have, when you were in Miami and doing it, where this where you lived. Okay, I'm sorry. There were a lot of Spanish-speaking people.
Yeah.
Do you think that the difference between there and here is because, and I know the group that you work with were all Spanish-speaking as well.
Yeah.
But a lot of times we have a discrepancy, and I oftentimes wonder how Latinos are getting information about their health care, the medication they take, their diagnosis, whether they fully, if they don't have an interpreter or don't fully understand English, whether or not they're getting the right diagnosis or the right medications or taking the medication correctly. And so there's, even if you have translators, a lot of times translators do not translate it in the different dialects. So that may be a language barrier. So do you think if you did your study with all English speaking people who were translating the message, do you think that the survey would have came out differently? And I love your systemic survey that you did. So if I can have a copy of it, please send it to me.
Thank you. Thank you.
But that is one of my questions. The language barrier is often a problem with Spanish-speaking people, and whether or not they truly understand what is being said. If they don't have a child that speaks English and Spanish going with them to doctor's appointments, they may miss what a person is trying to tell them.
Yeah, you have so many good things that I would love to talk about. So many aspects of your questions that are really good. First is that in both places, the majority of our participants were Spanish speaking, and all of our research staff spoke Spanish. So we were like, our team is bilingual, bicultural. So we don't, in our study, don't have a language barrier, but that language barrier does exist in the world of our participants. And so that would come into play in terms of, like, if there's a diagnosis, an HIV diagnosis, they may not, there's barriers in terms of getting access to care to be able to have a diagnosis, understanding that, etc. So I think that potentially goes into play. I think another really important thing is that in Miami, there's a lot of diversity in terms of the Latino subgroups that are there. There's a high proportion of Cubans and Puerto Ricans, which have higher risk for HIV than Mexican populations. Here in North Carolina, our sample was 54% Mexican. And so I think that was coming into play in terms of the risk that we're seeing. I pull this up, this figure up, because here, one of the things that, even though this is super old, I'm sorry, it's 2008, but there's not enough data that's presented where there's a consideration of birthplace, and that has a really important implications in terms of behavioral and mental health. And you'll see it here, the different colors. You see that like Mexican is in blue, and you see that they have like the lowest, the immigrant groups have the lowest rates of psychiatric disorders. And you see differences with significant differences between Mexican and Puerto Rican. Like there's huge. So Puerto Rican subgroups of Latinos are often that have the highest incidence of HIV, have the highest incidence of intimate partner violence, and the other syndemic conditions.
Our last question before we take a break.
Thank you very much for your presentation. I'm really interested in what you presented, because as an African immigrant, I could very much relate to a lot of what you're saying. So my question is, or will I say my comment is, are these findings generalizable to other immigrants? And does it, like,
other immigrants, and not necessarily just immigrants to the United States, but other countries as well, because like the world is becoming has become a global village. So people are always moving and, you know, settling in different countries. So how does these like findings can they be generalized to other populations as well? Yeah.
Great question. So I think that the immigrant paradox is generalized to not only Latino immigrants. We see it in Asian immigrants, and we see it in African immigrants, which are the groups that have been studied the most in the United States. And you see it across different types of outcomes. The most dramatic has to do with maternal and infant mortality. It's really dramatic, where you see African immigrants, in terms of infant and maternal mortality, have lower rates than Black American women in the United States. And then by the third generation, the maternal and infant mortality indices are, they're Black American indices, they're the same. So you see this decay of health when it comes to that. So you see it across conditions. I think it's unique here in the United States because, as we know, like we have very poor health outcomes compared to other countries. And so immigrants are bringing some of their healthy behaviors and outlooks and their resilience to the United States. And while in the United States, our environment, unfortunately, is not allowing for those groups to maintain those protective factors. And so there's this decay that we see. I imagine there is some commonalities around acculturation to the context and the impact that has. But I don't know if it will be as dramatic as it would be here in the United States. That's actually something I'm really interested in doing in the future.
And Rosa, just passing along a comment from one of our D3C members online, Aleda, who works in Mecklenburg County with Latino Commission on AIDS. She says, thank you so much for advocating for the Latino community, and I hope you all can connect afterwards as well.
That would be great. Thank you.
Thank you.